make presentation. And today the presentation is somewhat eye-catching topic, Mission Impossible. And this is presented by Dr. Teklani, who had her primary education at Teklani Dharma Law College and Milagiri St. Paul's Girls College. And he did her graduation in University of Sri Jayawardhanapura and worked as an intern in Castle Street Hospital and LRH, and also worked in public health, a medical officer at MOH, Ministry of Health and Family Health Bureau, and as a SHO pediatrics at LRH. Then she did DFM in last year and joined with us with the MD selection. So I would like to invite Dr. Teklani to and wish her good luck for a great presentation. Thank you.
Dr. Teklani, your mic is muted. Dr. Teklani, your mic is muted.
Dr. Supan, can you hear me now?
Now we can hear you, yes.
Sorry. Good evening, everybody. Good evening, dear madam. Thank you very much, Dr. Prabhat, for that an introduction of me. I warmly welcome all the consultant family physicians present here today, dear madams, and my dear colleagues, my friends. And I warmly welcome you all to listen to my presentation. And my topic is Mission Impossible. And you know, before the postgraduate era, Friday night was the best day in the week. That was my movie night. So today I'm not going to talk about Mission Impossible next trailer. This is a very common scenario you may come across in day-to-day practice. But let's see if I accomplish this mission successfully at the end. Slides are moving.
Not yet, Dr. Teklani. Just click one more time to the screen and then it will start moving.
Okay. Okay. So I'm going to tell you a story of little Sarah, about a little girl who is just 4 years old when she came to me with her parents. Their main complaint was frequent passage of stools, which was loose, small quantity, and involuntary, that means passing without a sensation, that lasted for about 1 month duration. And I'm sure your mind is buzzing with the various thoughts, questions, and differential diagnosis. Don't worry, I'm not going to ask you anything at this point because I'm going to tell you more in this little story. How it all started. If you go back to 1 year, the case scenario was completely different. It all started at the age of 3 years. Started as infrequent bowel opening, which was gradually worsening throughout the last year. Initially, bowel opening was once in every 2 to 3 days time, then 4 to 5 days. Imagine, then it came as 7 to 10 days per week. That means bowel opening once or none per week. The stools were very hard, blocking the toilet. It was always painful defecation, and she was training a lot to pass a good bowel opening. Abdominal pain associated, which was only comes and goes away with each defecation. As always, her tummy is full with fecal matter. Her appetite was lost gradually, eventually led to poor weight gain. She showed features of withholding behavior with retentive posturing like straight leg, tiptoe walking, and back arching posture. She was seen by Several doctors, including pediatricians, they have started on various laxatives, cremorphine, lactulose, dietary advices were given. I'm not going to tell that her compliance was not always good, because there were some periods with good bowel opening, maybe responded to these laxatives, and her parents had to use lignocaine gel, which was applied on the anal area to relieve the painful defecation. The symptoms were continued for 1 year, starting at the age of 3 years to 4 years, with worsening of symptoms. Then later they found there's very mild response to treatment. Finally, when they presented to me, she was having fecal soiling. That means frequent small quantity loose stools, which was embarrassing to child as well as parents, which avoid many social gatherings. Stool were not contain any mucus or blood, and the disease was not associated with any constitutional symptoms, especially fever, which can arrive at a diagnosis that couldn't be any infective cause. So basically, what else would you like to know? And this is there's no magic inside this. I'm asking in broadly what else you would like to ask in a pediatric history, which could be different to adult history. And I'm going to build up the story with the help of you all. Could you please someone tell me what else would you like to ask, just the topic wise?
Her growth, regarding her growth, whether it was normal, appropriate for the age.
Yeah, good.
And her diet?
Yes, diet, very good. Any other things in a pediatric history?
And milestone achievement.
Yeah, very good. Yeah, milestone achievement.
And about her diet in related to this history.
Sorry, Dr. Sindhupa?
Yeah, about her dietary practices.
Yes, dietary practices. Yes, it's very important.
Social,
What happened?
social circumstances.
Yes, very good. Social circumstances. Social history.
Whether she's having any psychological stresses?
Yeah, sure. Psychological stresses. Excellent. Okay. Since there are more questions times, I'll move to the next components. So I told this is very basics. We have to think about each component in a pediatric history, past medical history, surgical history, and as you said, dietary history, social history, development, and growth. Yes, and I will include psychological aspect also. And let's move. In the past medical history and surgical history, why do you think it is important? And what are the key things you are going to ask, not only in this encounter, but broadly? If you come across a patient with similar scenario, what are the things you are going to ask in the past medical history to get more information?
Has she underwent any surgeries before?
Yes, Dr. Finas. Yes, yes, that's very important.
Yeah, abdominal surgeries.
Yeah, sure, yes.
Previous diagnosis of Hirschsprung.
Yeah, excellent, yes.
Any thyroid hormone assessments?
Yeah, that's very important. And it actually basically include into investigations, but I take it as any clinical symptoms. You mean clinical symptoms related to thyroid disorders? Yes. Yes, Dr. Varuni.
And about any features of toilet refusal syndrome, like whether she refuses to pass stools in the toilet but use it for the micturition, and sometimes insist on having a nappy or anything to pass stools.
Yes, sure, sure. Yes, Dr. Sindhupa, yes, they have to ask. Okay. These were the things I focused on the history. Any other diseases she was suffering from, and any history of diarrhea and altered bowel habits prior to this constipation. And were there any recurrent respiratory tract infections, especially pneumonia? You will understand why I looked in this, especially in the history. And symptoms of fatigue, lethargy, decreased activity. This is more related to thyroid disorders. And change in bowel habits after introducing certain food items. Whether with this constipation, she had any urinary tract infections. And as you said, any surgery she has undergone. And our little Sarah, other than one episode of culture-positive UTI at the age of 3.5 years of age, she did not have any of the above symptoms. And antenatal and birth history. Would you like to know anything interesting particular to this story? Is it important, antenatal and birth history? Hello?
It is important, but since you presented initially
Yeah.
that frequent passage, then I was wondering what to ask in the soon after the birth history.
Sorry, Dr. Supun?
If the child has not passed
Yeah.
schools at the initial period, then there may be a history of trunks.
Yes.
But since this child did pass stools, I can't think of questions what to ask in this related to this problem specifically.
Okay, yeah. And since you saw this previously, accidentally I pressed it. And I would like to ask, these are not very much important in this this scenario, but anyway, if this is a planned pregnancy, previously rubella immunized and taken folic acids, whether she had any antenatal complications, maturity at the time of birth, mode of delivery, any birth complications, birth weight, and as Dr. Supun mentioned, if the passing meconium time, if whether it has happened less than 48 hours. So in Sarah's story, it was a planned second pregnancy and no significant antenatal complications. Term baby delivered by elective cesarean section. Birth weight was 2.4 kilograms with no birth complications, and she has passed meconium within 24 hours. And as you said, development and growth history, what are the key points you would like to know?
Whether she was potty trained.
Yeah, yes.
And growth, growth is within the normal range. I mean, age appropriate.
I think some of you mentioned regarding the milestones and all the things previously without taking time. I would say yes, as you mentioned clearly, weight gain, how it happened, and developmental milestones, social interactions, physical activities, and schooling and performance at school and nursery are also important. And developmental milestones under that, toilet training comes in. So here we go. Weight gain was satisfactory until all these symptoms were started. And with the worsening of symptoms, growth flattening was observed. No delay in milestones, except no proper toilet training was achieved, although it should be achieved between 18 months to 30 months. She was at the time of 4 years, still no proper toilet training was seen. At the nursery, there was poor performance, lack of interest, and there were multiple complaints from the teacher about her performance. And she was engaged in less physical activities, more towards a sedentary lifestyle. And this is the growth chart. You can see she was born with 2.4 kilograms until 6 months. Actually, she was trying to cross the lines. And then after 1 year, it's a normally, I don't take it as an abnormality because normal refusal of feeding can be seen among pediatric group after 1 year with starting adult diet. Then can you see at the age of 3 years, And 3.5 years, can you see a growth flattening? Then again, close to the 4 years time, again another growth flattening seen. And right hand side, there's a height chart. You can see it is going nicely parallel to the lines. And is there anything significant in the family history, allergic history, immunization history?
In the family history, I think in some literature there are evidence to show that family history of constipation, mainly in the first degree relatives, is it's a clear predisposing factor. And also in the yeah, that's it, I think.
Yes, I would add that point. Yes, family history of constipations and also Hirschsprung disease and allergy to any cow's milk, and immunization is not that important here. But anyway, to complete in the sake of history, yes, I would ask those things too. And Sarah did not have, not in the family, also didn't have any constipation history among family members or Hirschsprung's disease, or she did not have any allergies or anything significant in that component too. And the dietary history, I would like to ask breastfeeding duration. When was the complementary feeding started? Any change of bowel habits when introducing gluten-containing diet? And how about her diet? Her diet is, it's a balanced diet with lots of fiber, fruits and vegetables, fluid intake. When I inquire, these are the things I found. She was exclusively breastfed for 6 months. Complementary feeding started at 6 months and given accordingly. But with the starting of nursery, dietary pattern changed. Lots of junk food was given and low fiber intake was seen because during the daytime in the nursery, there's less fluid intake was seen. Social history, as you mentioned, I'm not going to ask again. It's important to find out the family background, educational status and income of parents, any psychosocial issues in the family or school, any major stress factors within this period. Yes, there are lots of information I gathered in the social history. She was the second child in the family, only one brother, who is elder brother is 3 years older than her. Parents were well educated and in professional fields, satisfactory income, no family disputes in the family. But as school started, that environment was not a happy one for this girl. Her routine pattern was changed. Teacher was a strict one, always complaining, expecting to be perfect. And her confidence, interest, performances showed significant change, and fear of using the common toilets in the school, which aggravated her condition. So, what are your thoughts now? What are the thoughts in making a differential diagnosis? Can you please give me differential diagnosis? It's a very simple thing.
Poor dietary habits causing constipation, and it aggravates the condition. As a vicious cycle, it aggravates day by day.
Okay, sure. Yes. Anything else? Commonly, if you encounter a patient like this, what are the
any causes, any symptoms regard the attention deficit hyperactive disorders?
Why do you say like that?
Because a teacher is complaining, but we have to ask that whether the child is start activities and all.
Yeah, she was not a hyperactive child. I didn't mention that, but I can tell you she was not hyperactive one, very silent character. And yes, attention deficit at her circumstance, it's very unlikely.
and you told she's refusing to use the toilet.
Yes.
There are some children who have associated phobia like
Yeah,
this,
excellent. Yes.
for toilet using, and
Yes.
also it is associated, sometimes it is associated with that stool withholding, and it
Yes.
leading to a vicious cycle, as somebody told.
Yes.
So
Teklani,
perfect
sometimes
answer.
this
Yes.
child might have not drink water much because it also cause more frequent using washroom. So it also aggravates the condition further.
I didn't get you. That means she's taking more fluids.
No, she's not taking more fluids because if she take more fluids, she
Yes.
again want to go to the washroom again.
Maybe she's you are telling that to prevent going to she's okay. But the thing is, in the nursery time, they are allowing to have the fluids only during the interval time. Honestly, that's how it happens in our schools. They have to keep the bottle of water some other place, but during the before going to the nursery, she was at home. At any time she can have water, but actually in the nursery she's only having once or twice. Yes.
I think the strict teacher at the nursery affected her. I think the strict teacher at the nursery affected her behavior.
Yes.
And whatever toilet training she got at home, she lost at the school.
Yes.
And that even then when she comes home also, she wouldn't probably open the bowels routinely.
Yes.
And that led to the vicious cycle of fecal loading and overflow diarrhea and so on.
So because you all actually gave me reasons for one major diagnosis. Still, we all are contributing to one diagnosis. Can anyone name that? Is there some name to all these collectively talking about one diagnosis? Can somebody?
Yes, Teklani, this is a functional abdominal pain in children.
Yes, I think it's Dr. Farhat. I can't see who's talking. Yes, Dr. Farhat. Yes. So without wasting time, yes, in the hierarchy, it's functional constipation. All you talked, I can gather it into one condition. But still, keep on your back of your mind, still, these are also, though they are rare, we have to keep in mind. Metabolic causes could be hypothyroidism, hypercalcemia, and still Hirschsprung's. Yes, I will keep it like that. And gluten enteropathy, that is celiac disease. There are some studies shown constipation, although it is present more with diarrhea, still failure to thrive with constipation. Yes, we can take it as gluten enteropathy. Cystic fibrosis, I think I should have more down because she didn't show any history of recurrent respiratory tract infections, but I just kept it that also. And neurological abnormalities, but if there are neurological abnormalities, the presentation would be much early in life, especially in the infant period. And also congenital anorectal malformation, just for the completeness, I thought, because you may come across similar case scenarios. That's why I put them like this. But still, functional constipation is my number one diagnosis, as Dr. Farhat mentioned, and all my colleagues contributed towards that. And in the examination, what are you going to look for? What are the key things? Only the key things. Now you know it could be functional constipations and all the other things also there. And what are the things you are going to look in this little girl? Not, I mean, broadly, what are the things you are going to, first tell me, what are the things you are going to see?
Baby's mood.
Sorry?
Baby's mood.
Very good. Mood. Yes, very good. Yes.
Child's height and weight, we have to check it.
Yes. already I showed growth and chart, but still, yes, it comes under examination findings, yes.
And as in any pediatric examination, we have to see whether the child is having any dysmorphic features suggestive.
Yeah, very good, very good.
And features of hypothyroidism.
Yes.
And whether there is any abdominal distension, and we have to check the spine as well to see whether there
sure.
are any.
Yes, neurological examination, yes, fine.
And the rectum and the anal area, we should check for fissures and all.
Yes, yes. Any other things you would like to tell me?
The behavior of the child, how she interacts with the mother or the other sibling and the doctor.
Yes, sure. And I think if I happen to present this in another forum, I would include all your ideas, because actually I didn't think some of the things. Yes, general examination, I would look for any nutritional deficiencies with this growth flattening, whether she's anemic or any other nutritional deficiencies. And weight and height, any other systems, especially neurological examinations and abdominal examinations, including digital rectal examination, is very important. And here what I found, as someone told, she was a very anxious little girl, because she knew she has gone to several doctors with extreme fear of if I perform an anal examination. And she's thin built, no features of iron deficiency or the nutrition deficiencies I couldn't elicit. The abdomen was distended, and it is gaseous distended abdomen with lots of fecal masses. And lower limb neurological examinations, including spine, perfectly normal. And in the digital rectal examination, at that point, I couldn't detect any anal fissures, and anal sphincter tone was normal, and the position of anus was normal. And after DRE, I could see fecal matter. And these are the key points. Now, you know, I don't have to repeat. She's initially had constipation, then fecal soiling, abdominal distension, growth flattening, poor school performance, poor social functioning, lack of proper toilet training. These are the problems after a complete history and examination. And still, what are your thoughts in the differential diagnosis? Let us see. Yes, functional constipation still in the top. And metabolic causes, I still can't exclude, but I can exclude Hirschsprung's after the history, and gluten enteropathy, cystic fibrosis after the examinations, neurological abnormalities. So we are left with functional constipation and metabolic causes. Now the pathways mission little bit easy. And let us find some clues to solve the mission together. Investigations carried out. What do you think basic investigations that we needed at this point?
Thyroid function test.
Yes, thyroid function.
Full blood count.
Yeah, basic investigations. Anything?
Serum calcium.
Yes, very good. Okay, basically those things. So other than that, I would like to do UFR and urine culture, because she had one past episode of UTI with culture positive with E. coli, responded well to antibiotic treatment. But still, I would like to do UFR and urine culture, because with prolonged constipations, these kids can get UTIs. And thyroid function test normal, there's no hypercalcemia. Hemoglobin was 11.9, full blood count, it's okay. And liver function, serum creatinine, they have done, but they all are normal. So what are your thoughts again? Now we have excluded our metabolic causes too. So now we are left with functional constipation. Do you think mission completed? In every movie, that is not so. In every story, that's not so. What happened? In the meantime, one day, the girl got severe abdominal pain, and parents noticed distension was more than the other days. And because they are well-educated parents, they are always reading and searching in the nets. Not like other parents, they are scared of bowel obstruction, and they immediately consulted a pediatric surgeon in the private sector. What do you think that happened? They did some investigations, scan, you know, in the private sector, you can do all sorts of investigations without thinking. I'm not blaming, but these are the findings. Gaseous distension of abdomen due to constipation, prolonged chronic constipation, and distended rectum, and the rest of the scan is normal. And they have also done plain erect X-ray abdomen. Can somebody tell me what can you see in the X-ray, whether, as the parents, anxious parents thought, is this really an intestinal obstruction or something else? Can somebody tell me what are the findings? Is it clear?
There are multiple fluid levels suggesting of intestinal obstruction.
Yes, Dr. Chaminda, yes. Any other guessings?
Gaseous distension of the bowels also there.
Yes, but I like to add always when reporting the things, we have to correlate with the clinical findings other than abdominal pain, other than abdominal distension and worrying anxious parents. She didn't have any other clinical symptoms like vomiting, fever, and she was passing flatus, and clinically it is not suggestive of intestinal obstruction. Yes, but yes, I agree with you. There are distended bowel loops with multiple fluid levels, and there is some important thing you can see. Can someone tell me?
The rectum is full of feces.
Actually, rectum is, Dr. Sindhupa, it's absence of feces. That is the alarming sign. Yes.
Okay.
Yes, thank you. Anyway, that is the alarming sign. And all the other bowel distended, gaseous, full of feces, but rectum, according to the X-ray reporting, this is the suspected thing. If it is short segment Hirschsprungs, which appear with the similar symptoms, but later in life. Do you agree with or not? With a single report done nicely, we thought we are on the correct track of functional constipation, and family physician was ready to start again the treatment for that nicely. But with this thing, are we going to deviate or what?
Dr.
What are your
Teklani,
thoughts? Yes.
once we did the rectal examination, there was feces, isn't it?
Yes, once, not in this scenario. In the first encounter, there were feces. Yes, correct. But this, after reporting by a radiologist, they told this is more likely to have a short segment Hirschsprungs because in the rectum area empty with stool. Yes. So, what are your thoughts on making a differential diagnosis? We are in trouble, right? Anxious parents again came with this report because pediatric surgeons suggested lots of things, whether this is short segment Hirschsprungs or functional constipation. What are your thoughts? What happened next? Any guesses?
Can't it be a congenital band in around the rectal area? Obstructing the.
So why it delayed up to 3 years to start the symptoms? If it is something congenital, I agree with you. The presentations would be much more early in life. But yes,
usually like that, but
yes,
can be.
But can be, yes, yes, I agree. You want to know what happened in the story?
Yes.
Yes. The pediatric surgeon suggested to do a contrast barium enema. That's the correct pathway to exclude Hirschsprungs, especially short Hirschsprungs, to see any transitional zones of empty rectum. like that. And then if the contrast barium enema become positive, what more investigation we have to do to this girl? It's rectal biopsy.
Rectal biopsy.
Yes, to find out any ganglionic areas in the rectum. So what more? What will happen to this kid? If the biopsy is confirmed, what is the treatment pathway? What is it?
Surgery. Yes.
Yes, surgical resection. And do you know what happened? Parents did not want to proceed anymore. They were fed up with all the investigations, all the treatments, all the time. And now they ended up having another disease. They came to the family physician and told, no, we don't want to proceed anymore. So what do you think that what happened? Even if it is intestinal obstruction, after 3-4 days, they came with the report, nothing has happened. The child was perfect other than the mild abdominal distension and a chronic problem. And they both chose the easiest pathway to solve the problem together. Keeping aside the short segment, that hard pathway, with watchful waiting and safety netting, explaining all the red flags, yes, they just took the easiest pathway. Watchful waiting. Yes, still we can just give a try if this is still functional constipation. Why with one single investigation, why do you want to destroy that whole story and taking that hard pathway and harassing this little girl? And you know, after even resection, do you know the treatment after that also? It's again laxatives and more complications. She can get more fecal incontinence. Why we are not trying the other pathway? So still, this is not only my decisions, negotiating with parents, I still take this as functional constipations, and I will tell why. And this is somewhat boring thing now. Do you know the definition of constipation, especially functional constipation?
According to the ROM4 criteria, we can define that.
Yeah. Yes, very good. Yes, as you mentioned clearly, ROM4 criteria, initially this was started in, because there are a number of definitions for constipations, it's like an umbrella term, but to understand the pathophysiology, epidemiology, treatment options, they built ROM criteria initially as 2, then 3. ROM4 criteria was made in 2016. All the criteria were same, but only the persistent symptom duration was the only difference. In an example, ROM2, it was symptoms should present for at least 3 months, but in ROM3, 2 months. And ROM4 criteria, symptoms should present for at least only for 1 month, and 2 of these criteria you can go through. I don't want to read it out. And only 2 or more, at least 2 criteria should be present for 1 month durations. Why this symptom duration they modified? Functional constipation is a thing you have to detect early as possible and to intervene as much as possible to prevent further consequences. This is not an easy thing to, even though this is a very simple thing, you may think, but compliance, relapses, and it takes a long period to have a good outcome. So it is always want to detect it early as possible. So if the symptoms are present for 1 month, according to our story, you can see that girl had all the symptoms. Can you see? And findings consistent with functional constipations. Stool passed, she passed stools within 24 hours, extremely hard stools with large caliber, and fecal soiling, and avoid potty toilet training, and all the
Dr.
symptoms are
Teklani,
present. Hello?
we can't hear you.
No, we can.
You can't
We
hear
can
me?
hear you.
Oh, okay,
We
sorry.
can hear.
I thought accidentally I muted my mic. Yes, and she had all the criterias. And but if following features are present, you have to investigate more to find other diagnoses, especially as we mentioned and talked early, if the constipation onset extremely early in life and passage of meconium more than 48 hours, and she was passing ribbon stools and absence of blood in the stools because with the full functional constipation, still she can get anal fissures and mothers can complain blood in the stool, but if there's no anal fissures, you cannot have blood and failure to thrive or unintentional weight. But in this story, these are the bit alarming things. There's growth flattening. We can take it as failure to thrive and abdominal distension that is not that severe, mild to moderate. And there's no fecal incontinence without any rectal impactions. All the time, her rectum is impacted with feces and no abnormal examination findings according to the story. So we are only with failure to thrive and abdominal distension. All the other components, like in this slide, favorable of functional constipation. And this is why I asked you, I actually paid more attention towards these things in the history, especially we talked about hypothyroidism, and there are rare cases with cystic fibrosis and gluten enteropathy with constipation. And congenital anorectal malformation, as Dr. Chaminda mentioned, it appears early in life, and Hirschsprung's disease. But here in this category, they have actually not mentioned short segment Hirschsprung's, how they relate. And if we talk about epidemiology, I will go through this quickly, otherwise you will fall asleep. There's a global prevalence of 9.5%. And initially they thought it is only seen in developed countries rather than very low in Asian countries, but there is no more. There are certain studies conducted in Sri Lanka which showing 15.4 prevalence of functional constipation, especially high prevalence seen in Galle, Ampara and Badula districts. Why this is important? It leads to significant healthcare expenditure and affects directly on the quality of life of children and their academic performance. So it's a burden. And several studies showed, although I inquired the education level, family income, socioeconomic status, employment, none of the studies could show there's a strong correlation between these factors. And if I explain risk factors for functional constipations, there are central causes, which is related with brain, and peripheral causes, which is gut related. And you can see, I don't have to explain more, now you know, stressful life events in little Sarah's stories, there are lots of stressful life events. But other than that, in any of the child, you have to ask any bullying in school, separation of parents, family disputes, and especially abuse. There are several studies shown there's strong correlation with child abuse, not only sexual, but physical and emotional, and maltreatment at any place, at any environment can give rise to functional constipation. And psychological and behavioral issues as in this story. She started her nursery with so much expectations, but with the strict teacher and changing her normal environment, being with parents and grandparents, it just dramatically changed her everything, day-to-day routine. And psychological state of parents. If the patients are over concerned, they want to train their kids with toilet training early, and that can lead to poor outcome. At the same time, if the patients are neglecting, and that also can result to poor toilet training. And as you all mentioned, toilet training plays a major role in the central causes of functional constipation. And these are the peripheral causes. I don't have to repeat the same thing. Diet, physical activity. Why? This girl overconscious patients. They are not letting her to play in the garden because of dengue and everything. She's more towards a sedentary lifestyle, and she's a girl with her own toys. She just sit and play or read, and she paints. So reduce physical activity, less intake of fluid, and eventually it can lead to constipation. an abnormal microbiota, but very less evidence to suggest that microorganisms, normal healthy microorganisms present in the colon, they increase digestion, increase absorption, but sometimes presence of bacterioid-like organisms can change the pattern and lead to constipation. And if we talk about pathophysiology, stool withholding behavior is the main role in pathophysiology. If we describe it as once somebody told, it's like a vicious cycle. That's exactly correct how it happens. In one occasion during the lifetime of kitten, if there is a mild to moderate, even mild pain on defecation, that signals a brain that she does not wish to defecate because she doesn't want to experience that similar painful thing. So what happens? She tries to avoid other tightening the external anal sphincter, squeezing the gluteal muscles. These are the retaining posturing things like straightening leg, back tipped over like that. She's like to withhold. What happened? Frequent avoidance of defecating. Rectum eventually stretches to accommodate more and more feces, and more feces will retain. And in this case, while there was distended abdomen not due to intestinal obstruction, when the feces remain in the rectum, what happened? It stretches more, can accommodate, and it gives rise to megacolon thing. What happened? Then when normally in a normal kid, when the rectum is full of feces, you get the sensation, urge to defecate and bowel opening. What happened when the rectum and the colon stretches? She or he doesn't get the sensation to urge, and it can lead to more retaining of fecal matter inside the colon and the rest of the bowel. So again, then collection of feces will absorb more and more water, and it will make hard and large stool, and it will be difficult to pass, and a vicious cycle. This we have, and it ended up with functional constipation. If we don't break this vicious cycle at any point of the cycle, we cannot actually do nothing. We cannot stop this. We cannot treat. So if consequences of untreated, I only talk about the very simple consequences. Physically, emotionally, and school performance can greatly affect. And the child, to prevent schooling and other activities, she may complain of variety of somatic symptoms like abdominal, not only abdominal pain, other somatic symptoms, and she tries to avoid many social functioning and school. Are we in the correct pathway? What are your thoughts? Because I told you gave you information regarding functional constipations. Are we still in the correct pathway? Do you think I did a mistake? Hello? Are you sleeping? Hello?
Hello, Teklani.
We are here,
Yeah,
Teklani.
we are here.
Is it a correct decision to treat this child as functional constipation and not investigating those things to exclude short segment? Am I in the right track?
Yes, I think family physicians, we can do that. We can take time as a diagnostic factor.
And watchful waiting with
Yes.
safety.
I'm happy.
Teklani here.
Yes.
Teklani, now what it's very contradictory, what your the statements and everything. You know, like you nicely explained the pathophysiology, what will happen with functional, constipation, there's pooling of stools in the rectum and it stretches and it accommodate more stools and everything, right? It is for the functional. Yes, and, just forget about this diagnosis of segmental Hirschsprung's. Like that particular, the radiologist finding shows empty rectum. That was my, the query. Why he says empty rectum? It's a big statement.
Yes, madam. When I dig into history, this mother was using enemas time to time. and she can't remember because to disinfect they were using enemas. And I think because she cannot remember it very well, I think on that particular day maybe she has used enema, and only enemas and laxatives like lactulose only empty the rectum, madam. So it could be that, because actually before the presentation
they are under treatment of somebody. Do they recommend to use those enemas if they are under treatment of somebody? Because, you know, like he's waiting for this much of huge investigation, right? And then definitely under the supervision of somebody, like they are under the treatment of somebody. So do they allow them to use all these enemas or laxative without their sort of knowledge? It's a problem. We have to find answers for that.
Yes, I agree, madam.
And Dr. Teklani, just for the clarification,
yes,
I'm not sure whether it is done in LRH or not. What about anorectal manometry? Is it done in LRH?
No, it's not
sure.
done. Actually, that is the correct pathway after the rectal biopsy. In other countries, they do anorectal manometry, but I inquired them, but they are not doing at LRH. Yes.
The thing is, you know, like it's order is very nice now. I love the way you presented anyway now. And the thing is, with the very first slides with the presentation, I think it's better, you know, if you could add more regarding child abuse here. So you have not mentioned much about child, because the very first time when you give all the information, I thought it's better you put more on child abuse. Because whether it's either the negative findings are very important. You say no such history of child abuse.
Yes.
Either the, you know, whatever the way, like either it could be sexual, it could be psychological, verbal, whatever the way.
And I can take it as, madam, I don't know if it is emotionally the child is abused, but the teacher was not that abusing.
No, don't like think about only the blame to the teacher.
Yeah,
There
yes,
are a lot
madam.
of
That's why I didn't
instances.
take it. Yes, madam. I couldn't gather anything that like, because that is some teachers are like that, perfect. They want perfect outcome in every aspect. But I didn't take it actually as even a minor emotional abuse. Yes.
And
because she
also
was in a very competitive nursery. Yes, that's
No. This one here, Teklani, not only the nursery teacher. There are instances even at home, maybe relatives, maybe whoever, right? If a patient comes, you know, without this much of it's a dilemma. We don't know what it is. So better get that history. That's what I was thinking.
Yes, madam. Yes, thank you, madam. Yes, that's something I lacked in the history. And these are the management, basically non-pharmacological and pharmacological management. You have to start simultaneously to achieve a good result. And education, reassurance, dietary adjustment, and toilet training. Especially in toilet training, I would like to share what I applied to this kitten. She was very scared. She was not at all using the potty or toilet when I encountered her, because she has, as Dr. Sindhupa mentioned, she has some phobia. She didn't like the bathrooms. She's scared, and because she always wanted very clean bathrooms, and she used to hide in a corner of door and used to do those things. So I told, it's okay. Then I asked the parents to go to a shop and to buy a potty with her favorite color. So they bought it. The kid chose it. Then I advised the child to sit on the potty after every meals, but only for 10 minutes, no more than that. That's it. If even though she opened her bowel or not, that's it. So, and meantime, we have to start oral laxatives. In those days, they used to give enemas, But in the new guidelines, they say polyethylene glycol, Movicol is the best thing, best out of all the osmotic laxatives managing functional constipation. In this child, as she is 4 years of age, I asked them to give 1 sachet per every day. In foreign countries, there are pediatric preparations, but here we only find adult preparations. But in studies also, there were very minimal side effects, only bloating of the abdomen, mild abdominal cramps and diarrhea. I explained the parents that they could find these things, but still continue. And we have to dissolve the sachet in 125 milliliters of water to make it more tasty. I asked them to only add 100 milliliters water and 25 orange juice, natural thing, something like that. Anything she likes. And to give it, luckily that was her vacation time. She was at home, so it made me easier. And I asked to give this sachet dissolved in water and orange juice every day around 10 a.m. and she has to take it within 30 minutes of time. Initially, it was not an easy thing, but giving her favorite glass and straw and lots of behavioral interventions I had to do. And then gradually, then after giving polyethylene glycol or Movicol, you have to sit after several hours, because with the laxatives, other laxatives, they only empty the bowel, fecal matter in the rectum. But with this Movicol, it helps to disinfect all the fecal matters, not only 1 day, but when we gradually use for several days, it helps clear the fecal matter slowly. And initially, when we start with a high dose with Movicol, at the same time, you have to continue the normal maintenance therapy with lactulose or cremophene syrup. But the most important thing in the toilet training and behavioral interventions, anyway, mother is educated with the dietary adjustments, fiber diet, fruits and vegetables, and increasing fluid. The most important thing is the toilet training and behavioral interventions. I asked the mother to give a rewarding system, display in a calendar or something, just to give a star. Initially, it was only few days on the calendar stars, and I asked them to give her a small gift. This is, I think, you know, I don't have to tell it, this rewarding system. And everybody praised her when he put a good bowel opening. Everybody praised, especially her brother, clapped and encouraged the little sister. And gradually, in functional constipations, this is not magic. You cannot cure it within 1 or 2 days, within weeks or months. It takes sometimes years to have the goal. And this is the treatment pathway and everything I discussed. And these are my references. And when with that management, what do you think? What happened to our little girl? Did the mission accomplished, or did I have to refer her back to the pediatric surgeon and to undergo that hard pathway? What do you think? Because in my mind, I don't agree with that X-ray at that time.
Hopefully the mission was
I can't hear you. I'm sorry.
Hopefully the mission was accomplished, Dr.
I'm sorry, I can't hear. I don't know, some problem with my side.
Can you hear me now?
Hello?
Yeah, I wanted to say hopefully the mission was accomplished.
Yeah, you think mission is accomplished. Okay, let's see. Yes, and you know, after several years, recently she celebrated her 7th birthday, and now mother is telling me with this treatment, with reassurance, believing of the family physician, and she has achieved that goal. She's not now using the common bathroom like other family members, and now she's in grade 2. She's enjoying her school life with lots of friends and lots of extracurricular activities according to her age. And you know, now she's asking her mother, Mom, you don't have to mark stars in the calendar because then you are going to put all the stars into all the days. Just just mark the dates only. I'm not going to the toilet because at the end, I think I successfully accomplished this mission. Because I strongly believe this is the art of family medicine, our discipline. If I just diagnosed with one investigation that short segment Hirschsprung's, yes, it still could be short segment to ultra segment. But there are debate whether to undergo surgeries. Still, there are some studies, yes, you can initially treat as functional constipation and see the response. So here I applied the basic concepts in family medicine which I encountered when entering this field. Patient-centered care is always superior to disease-centered care. And we have to approach a patient as a person. And we have to think in every aspect, holistic approach, how that anxious parents, how that anxious girl, why I want to do all the investigations and label her as short segment Hirschsprung's, when I can still with a watchful waiting, I give a try. That's the beauty in family medicine. So this is the end of my presentation. I would like to thank our coordinator, Dr. Lalanta Senarath Madam. Dear Madam, thank you for guiding me. And I sent you the presentation at the last minute and yesterday. And thank you for guiding me. Thank you very much. And all the other consultants I can't see because I invited my mentor, Dr. Dinesha Molligoda Madam, with whom I started my journey of family medicine. She helped me and guided me like a mother. And Dr. Sujiva Karnatilaka Madam, who helped me in the diploma in family medicine. And Malkanti Galhena Madam, I think because of the busy schedule, I'm sorry I can't see the participants. And I thank her and also Dr. Piyantha Halambayarachchi sir, who helped not only me in all the DFM batchmates during the DFM period. And Dr. Champika Madam, I think she's there. Thank you very much. I met her as SR during my diploma period. And I told you I want special thanks to few people. Especially when I select this topic, I need to thank my brother who is a consultant pediatrician. I'm not boasting. He is my brother who respects me and guides me. And thank you very much, although he's not here. And after selecting and agreeing with my brother, the next person is to contact Dr. Supun, Dr. Supun, the lecturer in the University of Ragama. Thank you, Supun Malli. He encouraged me even before the MD selection, and still he told, yes, Akka, even though it's a simple topic, yes, you can do. Thank you very much. And Dr. Tharindra, she's like a sister to me. She helped me choosing the topic and she helped me with the presentation. Thank you very much, Tharindra. And Prabhat, Dr. Prabhat, thank you very much for choosing the flyer and more attractive. But I thought participants will be more, but with this current situation, yes, nobody in a good mind. and I thank you everyone for listening to me and contributing with all your things, and just apply in every this, not only in this scenario, just try to apply our concepts first. And other than in emergency situations, yes, always we can take the easiest pathway. Thank you so much. And if you like to ask any questions, I'm ready. And Malkanti, madam, you are here. Thank you very much. I just only seen the participant list. Thank you so much.
Teklani, thank you so much for your excellent talk on this topic.
Thank you so much.
And yeah, your heading is impossible. Impossible itself say I am possible. You have done it. And
actually, it's possible, Farhat. I mission impossible. Poo.
okay.
Anyway, yes.
And I have one. I would like to ask one question. That is there any place of imipramine in a initial state of the treatment? Because it's imipramine. Yeah.
No, I didn't come across any in such a thing. Why have you read somewhere, Farhat?
Yeah. I had a lecture. I went to lecture in SLMA with Professor Shaman.
Really?
And he had a lecture on functional abdominal pain. So he nicely explained it's a kind of irritable bowel syndrome.
Yeah, irritable bowel syndrome, there's a place, but I sure for functional constipation because I went through several studies. Actually, Professor Shaman Rajendra has done all these studies. I'm sorry, but anyway, thank you very much. I will look into that. So did he tell for functional constipation also you can try it?
I think it's given for irritable bowel syndrome, diarrhea predominantly, because imipramine will cause, I mean, it will dry out the things.
Yeah, this is he explained when there is a functional problem, the brain and the GA systems are firing.
Yes,
so we
that's
have
why
to
central causes. Yes, Farhat, yes.
So we have to treat both. That's why he said that for the central system, we are going for some antidepressants. And for this, either constipations or a diarrhea, we have to treat accordingly.
Okay. Thank you very much. I think I didn't come across any of the things regarding functional. But anyway, thank you very much. I would read more and everybody can read and add because I'm sure Professor Shaman Rajendra is much more interested in this field and he has done several researches. Yes, Farhat, thank you very much.
Thank you, Teklani.
Any other questions?
Teklani.
Yes.
Yeah, very
Chaminda,
nice.
right? Indralal. Yes, Indralal.
Thank you for very nice presentation and congratulations for managing that patient. I have one question. You said that her teacher is a bit tough, right? Did you do for that?
Sorry?
Did you do anything or did you had any intervention for that?
Honestly, I didn't give any letter or thing. It's a very private school, very competitive school. And some teachers are like that. But anyway, I asked the parents to go and because they have never met the teacher and talked regarding this thing. So the several interventions I could do is because parents went and meet her. And regarding the education thing, I couldn't change anything. We couldn't, both parents and me. The thing is, but she allowed to drink her more water and helping her to go to toilet with another assistant helper. Those things she has done. But anyway, the kid, most of the time, because I asked them to give the Movicol in the morning during the vacation time. So she used to open her bowel around 3 to 4 p.m. in every evening. So that pattern I changed actually, Dr. Indralal. Then because when she was prior to the schooling, she used to just have to suddenly she's opening her bowel whenever possible. But now she's according to her mom, now she's opening her bowel in every evening as a routine. So I changed that pattern. Initially the teacher helped, but I don't think they don't with the 20 people, 20 kids, we can't expect more. But anyway, allowing her to drink because sometimes the teacher is shouting, not letting the kids to go and take the water bottle, distracting other students. But that thing I could advise, I could change that part, yes. Other than that, for strict, and because she's expecting at the 3 years also, she's expecting to draw squares and triangles. All the parents told it's very difficult, and actually the girl is a left-handed side. She couldn't follow the teacher's writing and everything. Then the parents went and explained that part also after discussing with me. Dr. Indralad, did you get the answer to your question?
Yeah, Teklani. Thank you very much.
Thank you. Thank you. Any other questions? Was it helpful for you? Because you may have treated so many constipation kids in your practice.
Yes, Teklani, it's a very good eye-opener to us.
Thank you so much, Finas. As always, you are encouraging me. Thank you.
Teklani, actually, this is not an uncommon problem. This is very common. Thank you.
Yes, that's why I'm telling. Yes. Yeah, I told there is a common problem because it's not a new thing. That's why I'm telling whether it's useful or not. But it was actually, it took me 3 years to achieve this goal. Yes, 4 years to 7 years. Now only she's using the toilet properly and all the things. Yes, hopefully we can continue like this.
So what are the, just mentioned the active ingredients of Movicol. So it's a very,
polyethylene glycol, madam. It's osmotic laxative, just like
it's of course, it's like that. It contains potassium chloride, sodium chloride, sodium bicarbonate, macrogol. Macrogol is the main sort of ingredient.
Yes, madam.
Macrogol is the main molecule. Main molecule is macrogol. Even for the palliative care, now what they use is this macrogol.
Yes, madam.
Not any other thing. So it contains equal amounts of potassium chloride, sodium chloride, sodium bicarbonate, and macrogol.
Yes, madam.
That that is a take-home message for
yes, madam. And I would like to ask you one question, madam. The thing is, when I handling this kitten, anyway, I was in LRH, but even in that institution, some of the pediatricians are reluctant to introduce this Movicol. It's a debate among the pediatricians also. They are always giving lactulose, but I don't know because I'm not actually
no, Teklani, it's because the Movicol is actually Movicol is not the actual molecule. It's a Movicol. Movicol is the
yes, madam.
Movicol. Now
yes,
the Movicol is
the Movicol. Yes,
yeah.
Yes, I know.
When it came, actually, it was a real molecule was available at the beginning in Sri Lanka about 10 years ago. Then again, because of the price factor, the Movicol came to the market. Madam. But that all the sachets is because we had to mix it with the, not water. A huge water, it's a little amount of water, but that particular sachet is designed for adults,
that's
not
right.
for children.
Right, yes,
that was the reason, not because of anything.
Yes, madam.
A bit reluctant to start.
Because I'm not involved in much of general practice. What about you and because you all must be having good exposure to these kind of situations, madam. In your situations, have you used this Movicol in a pediatric?
Movicol, of course, if it is a very, we'll say very stubborn, very stubborn constipation only. So we have, because if it really wants to use it for long term only, we have to use Movicol, right?
Yes, madam.
Otherwise, very short periods, we don't have to think, since it is not available as pediatric sachets.
Yes, madam. No pediatric sachets at all, madam, because in other
because that's what I told you. Yes, if it is very stubborn, constipation only.
Yes.
Otherwise, don't use.
Madam, when I read all these articles, I think we have to initiate it, madam, because in other countries like UK and USA, there are sachets containing some flavors like chocolate, strawberry. We don't have to add anything. But here, in case this child, even I don't know whether you have tasted it, madam, where that sweet taste is very not palatable at all for kids.
No, no, it's not palatable at all.
Yeah,
it's like it has a chemical taste as
yes, madam. So it's very difficult to introduce things, but I think rather than going into pharmacological, yes, we need the pharmacological therapy, but we can gain much more things by adhering to non-pharmacological things. But this is only one case scenario. But after I tackled this problem, I used to tell my friends, now also they are giving me a call and telling how to do this, because I am proudly telling that I achieved the mission, madam. But why can't we take a step and introduce this? If we come across, we still can use the adult Movicol, because nothing happened to this kid. But actually, this is one study. But when I read Professor Shaman Rajendran's articles, I think he also has mentioned that is superior to all the other laxatives. That's what, madam.
The pediatrician in Vatupiro Hospital currently, Dr. Chintaka Rajapaksa, uses Movicol a lot.
Right.
And he uses it. Sometimes he starts lactulose also, and then he has to continue it for 6 weeks.
Yes.
Until the child forgets the unpleasant
yes,
memory.
that's the thing, Dr. Supun. We have to make the child forget that unpleasant sensation, and we have to break the vicious cycle at one point. That's what how we have to treat functional constipation. That's theory behind it. Yes. There are no more questions.
So anyway, now it's nice to see all the slides. And
thank you, madam. I changed the color.
Okay.
Because you didn't like it, I know.
Okay then. Not only the color, the order mainly.
Yes, and Tarinda also helped me, madam. I was in a confusion state last night. I couldn't sleep well, but I hope.
Why you are in a confusion state?
Because I had only few hours to rearrange, madam. I went to hospital. I didn't get a leave.
Maybe you also constipated, no?
Because
madam, I hope I didn't make you unhappy.
No, because I was comparing the slides, and now
yes,
I'm
madam.
very proud. It's nice, good. Now the order is nice.
Thank you very much, madam.
Anyway, you got the points. That's why
yes,
actually.
Madam.
I mean, like telling you all, this is not to sort of discourage you all, but I've told everything to, I'm happy you got everything. The points I highlighted, then yeah, it came as a very nice piece of work then.
Yes, madam.
Good. Then I wish you all the best.
Thank you very much, madam.
Okay, then. Now it's 11 o'clock. We'll go for sleep then. Otherwise, you'll end up with constipation tomorrow. Okay.
Thank you, madam.
Okay.
Thank you so much, madam, for guiding us today. And thank you, Dr. Teklani, for that nice presentation.
Thank
See you
you,
all
Dr.
next
Supun.
week.
Thank you very much.
Thank you. Good night.
Good night.
Even though I didn't participate, Teklani. Hello?
Yes, madam. I'm here, madam. Yes, madam.
Yeah. I didn't participate. I was listening.
Thank you very much, madam.
Yeah. But the constipation, the management of constipation is a very good case, not only in the childhood constipation,
Yes,
but
madam.
also the adult. So better go through that and make the gaps filled with the extra knowledge with your colleague and all. That's really good
Yes, madam.
presentation.
Yes, they contributed a lot, and I need to read some more. Thank you very much.
Yes. So
everybody.
thank you very much. Anyway, it was an enthusiastic discussion. Good, huh?
Thank you
All
very
the
much,
best.
madam. Thank you for the participation, madam. With the
Okay,
quick
dear.
invitation. Thank you very much, madam.
Okay, good night.
Good night, madam.